Welcome back to Menopause University, or for purposes of our current unit and video, Gynecology University. I say that because we are addressing a disease that is not specific to menopause. Instead, it's something that can affect you at any age, at any stage of your reproductive or non-reproductive life. This is video number 457. It's the third video in our unit on PolyCystic Ovary Syndrome, or PCOS. Video 455 introduced PCOS as a disease that bears the wrong name because it involves 3 organ systems rather than just your ovaries. The 3 organ systems are dermatologic, reproductive, and metabolic. So instead of calling it polycystic ovary syndrome, we should call it permanent cardiometabolic ovary syndrome. Then, in video 456, you learn that there are 3 hormonal abnormalities emanating from these 3 different organ systems in PCOS. There's too much testosterone production by your ovaries, too much luteinizing hormone, or LH hormone, production by your brain, and too much insulin production by your fat cells. As you can see, with so many different things going on in so many different parts of your body, making a diagnosis of PCOS can be challenging, and that's what this video tutorial is all about, diagnosis of PCOS. There's nothing on PCOS in my book, in either the first or the second edition. My book focuses on menopause, and while PCOS will definitely affect your menopause, it's not specific to menopause. So, when you hear the word diagnosis, what comes to mind? Do you think a diagnosis derives from laboratory testing? Or does it require some kind of imaging study? How can a doctor diagnose PCOS when it's such an odd combination of organ systems and abnormal hormones produced by different organs? Let's walk through the timeline of PCOS events during one's lifetime, and let's identify the things that might contribute to making the diagnosis. And once again, we'll utilize and expand the chart we constructed in the previous 2 videos. Here's our chart showing you the 5 phases of your reproductive life in the first column. They're the colorful rows. And in the last 2 rows at the bottom, you see the abnormal hormones and responsible organs for each of the 3 organ system abnormalities of PCOS: dermatologic, reproductive, and metabolic. So let's just start at the beginning with puberty and progress from there. You've discovered that PCOS is not identifiable before puberty, and that's because before puberty, most of the things that contribute to PCOS are quiescent. Your sex hormones have not yet come into play. So puberty presents the earliest opportunity to make the diagnosis. Puberty is a time when you start developing breasts, you start growing pubic and axillary hair, and you start having menstrual periods. But if you have PCOS, you might notice a few other things. You might notice fine or thick, coarse, dark hair in places that you do not expect or want it, like your face, your chest, your abdomen, and your arms. In video 455, you learned that the term for hair in these locations is hirsutism. And you might have cystic acne. For most young women, normal puberty is enough to handle already. The last thing they need is these undesirable appearances of hair and acne. So the earliest tip-offs that you might have PCOS consist of hirsutism and acne. But not all women with PCOS have hirsutism and acne. This is one of the reasons PCOS can be difficult to diagnose at puberty. Well, you start having periods at puberty too, and they are supposed to occur on a fairly predictable monthly basis. But that's not what typically happens for women with PCOS. Most of them will tell you that from the very start, their periods were always irregular. Most commonly, they have them every 3, 4, or 6 months. For them, periods are random, unpredictable events. The other thing that happens at puberty is that you begin to gain weight. And normally, the distribution of weight gain is such that you end up with having a female silhouette that entails a larger bust, a smaller waist, and larger hips. We call this an hourglass shape. But for many women with PCOS, the distribution of their weight gain is more generalized. They gain weight everywhere. And instead of having an hourglass shape, they may have more of an apple or pear shape. An apple shape is disproportionately more weight gain in your chest and abdomen. A pear shape is disproportionately more weight gain in your hips and thighs. In either case, if you have PCOS, excess weight gain is very commonly a problem that begins as early as puberty. So, puberty is a perfect time to make the diagnosis of PCOS. Some or all of the hints are usually there. And the big key to successful management of PCOS is early diagnosis. And the great thing about making the diagnosis at the time of puberty is that all it takes is a doctor who listens to your description of periods and looks at your body. None of this even requires you to undress. Unfortunately, most women with PCOS do not get the diagnosis this early. Instead, they go to a dermatologist to treat the acne and hirsutism and never discover that their problem isn't just about their skin and hair. Some women start taking hormonal birth control to regulate their periods, but rarely do they get an actual diagnosis of PCOS before doing so. Most of the time, the hormonal birth control just serves to fix menstrual symptoms that are due to the problem without ever really identifying the problem and without ever really fixing the problem. And next week, you'll see that taking hormonal birth control for PCOS is one facet of the proper management for it, but by itself, it's just not enough. And you really need to diagnose the underlying reason for your irregular, infrequent periods, because PCOS affects a whole lot more than just your periods. So let's expand our chart to reflect the diagnostic features of PCOS at each stage of life. You can see that I've added a 5th column with the heading Diagnosis. And in the pink row for puberty, I've indicated that hirsutism, acne, apple or pear shape, and irregular infrequent periods are all indicative of PCOS. Now, I want to linger here a bit before moving on to reproduction. You can already see that the diagnosis of PCOS is possible with physical exam alone. But remember, not all women with PCOS exhibit these physical characteristics. Some have none of the dermatologic features. Some have completely normal body types without a hint of excess weight gain. Some have regular monthly periods. So physical exam is not always sufficient for making the diagnosis. And since hormone abnormalities cause PCOS, it is possible, and sometimes necessary or preferable, to use lab testing to confirm the diagnosis. And there is a long list of labs that can help in making the diagnosis. They include all of the following: FSH, which is follicle stimulating hormone; LH, which is luteinizing hormone; LH-FSH ratio; total testosterone; free testosterone; sex hormone binding globulin, also known as SHBG; and dihydroepiandrosterone sulfate, also known as DHEA. Prolactin, estrogen, cholesterol, HDL, which is high-density lipoprotein, LDL, which is low-density lipoprotein, triglycerides, thyroid-stimulating hormone, which is TSH, glucose, insulin, and hemoglobin A1C. We do not need to dwell on these. I just want you to know that there are many laboratory indicators of PCOS. It's one of the diseases for which we have lots of labs to help make the diagnosis. But just like the variability in the symptoms of PCOS, there is great variability in these labs. Some women with PCOS have abnormalities in all of them. Other women with PCOS have abnormalities in only one or two of them. Generally speaking, with PCOS, there are 3 lab values that are typically abnormal. First, your LH to FSH ratio is too high. This means that your LH is high, but your FSH is normal. I explained this in detail in the last video. Second, your total and free testosterone are high. This just means that you have too much testosterone, period. And third, your hemoglobin A1C is high. Hemoglobin A1C is a measure of insulin levels over a 3-month period of time. So the 3 most common abnormal labs are high LH to FSH ratio, high testosterone, and high hemoglobin A1C. These are the labs that reflect the 3 hormonal abnormalities that cause PCOS in the first place. So I'm going to squeeze those into our chart too. Now you can see that I've just inserted the 3 most common abnormal lab tests for diagnosing PCOS: high LH to FSH ratio, high total and free testosterone, and high hemoglobin A1C. Okay, so after puberty, when you discover that your periods are irregular and infrequent, you decide to get pregnant. And surprise, you fail to get pregnant simply by having intercourse without some means of contraception. You might wait months or years wondering why you haven't gotten pregnant. If you never discover that PCOS is the root cause of your infertility, then you probably never will get pregnant. If you decide to see an infertility doctor, you'll probably take infertility drugs, have in vitro fertilization, or do whatever it takes to achieve pregnancy. The collective name for all the treatments for getting pregnant is assisted reproduction. And there are many different kinds of assisted reproduction. But most of the time, once you pursue treatments for infertility, nobody bothers to diagnose the underlying reason for your infertility. Of course, Most infertility assessments include a pelvic ultrasound. And if you have a pelvic ultrasound that reveals multiple cysts in your ovaries, then you probably will get a diagnosis of polycystic ovary syndrome. The very word polycystic means multiple cysts. The problem is that many women with PCOS do not have multiple ovarian cysts. And with the very name of the disease being polycystic ovary syndrome, some infertility doctors do not realize that you can have polycystic ovary syndrome without polycystic ovaries. In any case, if you do achieve pregnancy, evaluation for the underlying cause gets tossed aside. So on one hand, it's great if you achieve pregnancy. On the other hand, if you do so at the expense of getting an accurate diagnosis, you put yourself at much higher risk for all the other aspects of PCOS. So on our chart for diagnosis of PCOS, let's designate multiple ovarian cysts as the diagnostic feature that can provide the diagnosis in the context of infertility. Now you see that I've created a row for diagnosis at the time of infertility. Obviously, you don't have to wait for infertility to exist in order to have a pelvic ultrasound that can reveal polycystic ovaries. But more often than not, that's the way it happens. It would be much better to perform pelvic ultrasounds on all women who have any of the typical PCOS features at the time of puberty or periods. In a perfect world, all young women would have lab testing and pelvic ultrasounds to either confirm or rule out a diagnosis of PCOS long before they attempt pregnancy. And if that were the case, they could avoid all the long-term, life-threatening aspects of PCOS. But unfortunately, that is not the standard of care. And remember, the standard of care is always about money. If a national healthcare system or an insurance company pays for your care, you're getting what they'll pay for, not what you deserve. Okay, so moving on. If you do achieve pregnancy with PCOS, you are much more likely to have complications of pregnancy. Some of the complications are early pregnancy loss, but early pregnancy loss or miscarriage is common for all women, period. So it's difficult to designate how much more common it is with PCOS, especially when most women with PCOS don't know they have PCOS. But later complications of pregnancy are not as common. They include gestational diabetes and gestational hypertension. And when you stop, you realize that with PCOS, these same things become problems later in life. It makes sense for them to manifest during pregnancy. But again, many women with these complications of pregnancy do not have PCOS. So you can't just assume that all women with high blood pressure or abnormal glucose during pregnancy have PCOS. And again, once you're pregnant, dealing with these complications of pregnancy, the focus shifts to ensuring the well-being of you and your baby. All interest in why you might have these problems in the first place becomes irrelevant. So there really isn't much of an opportunity to diagnose PCOS during pregnancy. Let's put this on our chart. So, the vast majority of women with PCOS get all the way through puberty, infertility, and pregnancy without ever learning that they have PCOS. Well, what's next? Perimenopause. Now this is where things get interesting. Most women with PCOS have had irregular and infrequent periods their entire reproductive lives. A regular monthly period is completely foreign to them. But alas, at perimenopause, their periods may become more regular and more normal in terms of timing. For the first time in their lives, they may have periods more frequently than every 3, 4, or 6 months. Now think about this. What would you think if your period suddenly became more regular and more normal at perimenopause? You'd probably assume that you'd outgrown whatever it was that caused your periods to be abnormal in the past. You'd assume that your problems were at an end, right? But in reality, your more regular and more normal periods are a disguise. Instead of signifying the end of your PCOS problems, these more frequent periods are a reflection of too much buildup of the endometrial tissue in your uterus. All those years of irregular, infrequent periods resulted in a persistently thick endometrial lining. Recall that I taught you in video 456 all about this. Focus on the last row here that depicts what happens to your endometrial lining if you have PCOS. Once the lining gets thick, there's a constantly low level of progesterone. And progesterone's role is to maintain this thick endometrial lining after ovulation should you get pregnant. But because you don't ovulate, this thick lining never sheds. So at perimenopause, you have a long-term buildup of the endometrial lining. And so because it's so thick, it just starts shedding more frequently. So instead of indicating that things are becoming more normal, your more regular periods mean that things are becoming more abnormal. For most women with PCOS, these more regular periods become very heavy. They have cramping, flooding periods that warrant a trip to the emergency room. The actual term for what they're experiencing is abnormal uterine bleeding. Abnormal uterine bleeding is uterine bleeding that is associated with failure to ovulate. So the bleeding is not a result of coordinated efforts between estrogen and progesterone with ovulation at mid-cycle. Instead, it's a result of failure to ovulate, followed by excessive buildup of the endometrial lining. So if you have PCOS, you'll typically start having more frequent but extremely heavy periods, heavy enough to send you to the emergency room. Well, what happens in the emergency room? You see an emergency room doctor who merely stops the bleeding. There's no attempt at diagnosing the underlying reason for the bleeding. The goal in the emergency room is just to deal with the emergent problem. The emergency room doctor will probably refer you to your gynecologist for anything further. But unfortunately, most women who have abnormal uterine bleeding due to PCOS never bother to go to their gynecologist to discover what actually caused the bleeding. They view it as a one-time event. And once the bleeding ceases, they assume the problem's gone. This is yet another missed opportunity. The PCOS is not gone. And its life-threatening manifestations are just beginning. Now, if you were to get an evaluation of the abnormal uterine bleeding, it would entail the very same things I taught you in the unit on endometrial uterine cancer. The first step is your gynecologic history. This is the most important step. I mean, if you come to me after having abnormal uterine bleeding during perimenopause, and you tell me that historically you had acne and hirsutism at puberty, irregular and infrequent periods your entire reproductive life, infertility, and pregnancy complications, and now you have abnormal uterine bleeding, that's a very easy diagnosis. In consultations, I encounter women with similar stories all the time. Unfortunately, most of them never received a diagnosis of PCOS. I find that most doctors are very lacking in their history-taking skills. History-taking requires listening to your patient, and most doctors aren't very good listeners. After the history is the pelvic exam. Your gynecologist needs to perform a basic pelvic exam to rule out obvious visible causes of your abnormal uterine bleeding. With PCOS, your pelvic exam will be normal unless your ovaries are enlarged by cysts. They might be able to feel those. So the next step is to get a pelvic ultrasound. The pelvic ultrasound looks at your ovaries, and it can determine their size and shape. If your ovaries are enlarged, it could mean you have any number of solid ovarian tumors. Or a pelvic ultrasound can also detect liquid ovarian cysts, the kind that you have with PCOS. So if it shows ovaries that are full of cysts, it serves to confirm a diagnosis of polycystic ovary disease. Another use of the pelvic ultrasound is to look at your inner endometrial lining. We can even measure the thickness of your endometrial lining. And if you have PCOS, most likely it will be thicker than it should be. The problem is that with perimenopause, a thick endometrial lining does not necessarily mean there's a problem. Remember, perimenopause is characterized by wacky periods anyway. So the pelvic ultrasound all by itself will not be enough to make a diagnosis of PCOS. But in the unit on endometrial uterine cancer, you learn that the other procedure for evaluating abnormal uterine bleeding is called an endometrial biopsy. An endometrial biopsy, or EMB, is a sampling of the endometrial cells that constitute the thick lining inside your uterus. This tissue sample goes to the pathology lab, where the pathologist examines it under a microscope. And that designates whether or not the cells are normal or not. In most cases of PCOS, the cells are normal. There are just too many layers of them. And all of your abnormal uterine bleeding is due to shedding of all the excessive layers of endometrial cells. Well, what happens most of the time is that the endometrial biopsy results are essentially normal, meaning that they do not show endometrial uterine cancer. And with that, most doctors and patients just stop looking for any cause of the bleeding. Ironically, perimenopause constitutes yet another missed opportunity for making the diagnosis of PCOS. Here that is on our chart. Well, as we all know, perimenopause leads to postmenopause, and that's when your periods cease forever. Now, if PCOS were merely a disease of your ovaries, it would die when your ovaries die at postmenopause. But PCOS is not merely a disease of your ovaries. It is a disease of 3 organ systems: dermatologic, reproductive, and metabolic. At postmenopause, the reproductive aspects of PCOS will stop manifesting themselves. This is because the abnormal hormone causing reproductive abnormalities is LH. And at postmenopause, LH is supposed to remain high permanently. The very problem with LH and PCOS is that it is permanently high before postmenopause when it shouldn't be. But the abnormal dermatologic and metabolic features continue in postmenopause. Postmenopausal women with PCOS continue to have hirsutism, acne, and obesity, and, most significantly of all, they have abnormal metabolism that affects them in all sorts of adverse ways. This is the life-threatening stuff. That long-term, thick endometrial tissue does not shed. So it starts turning into endometrial uterine cancer. Diabetes type 2 finally becomes evident, even though it may have been brewing for decades. Your cardiac lipids start spinning out of control, which puts you at risk for cardiovascular disease. And that causes an increase in your blood pressure, resulting in hypertension. And all of these things put you at very high risk of heart attack. Weight gain at the time of postmenopause is a very common thing for all women. But women with PCOS gain large quantities of weight very quickly. Most have always had a propensity for weight gain. But with the metabolic changes of postmenopause in general, and PCOS in particular, their weight problem really gets out of control. Obesity is about fat, and fat cells are what cause the insulin excess that is typical of PCOS. It's a vicious cycle. And all of these things contribute to fat accumulation in your liver. The name for that is fatty liver disease. There are actually two kinds of fatty liver disease, alcoholic and non-alcoholic. The fatty liver disease typical of PCOS is non-alcoholic fatty liver disease, or NAFLD. You know that all these metabolic manifestations of PCOS have really been present since puberty. But with all the focus on irregular periods, infertility, complications of pregnancy, and abnormal uterine bleeding, most women and doctors don't give them any attention like they deserve. At postmenopause, they all hit big time. There are diagnostic tests for all of these things that manifest at postmenopause, and you're probably already pretty familiar with most of them. For an increased risk of endometrial uterine cancer, you have the same test I described for perimenopause with abnormal bleeding: your gynecologic history, pelvic exam, pelvic ultrasound, and endometrial biopsy. For diabetes type 2, you have glucose and hemoglobin A1C testing. For lipids, you have a lipid panel including cholesterol, triglycerides, low-density lipoprotein, LDL, and high-density lipoprotein, which is HDL. For high blood pressure, you have your blood pressure checks. For obesity, you have your waist-hip ratio, or your body mass index. For non-alcoholic fatty liver disease, you have liver function testing. The problem is that at this point, these are all viewed as diseases of aging. And often, they are never connected to PCOS, which is what caused them all in the first place. So let's put that on our chart. Now you see that I've added all these diagnostic tests to the row for post-menopause. If only someone suspected PCOS way back in your early reproductive life, all these tests could have been done early enough to prevent the deadly diseases that result from PCOS. This is why it is so critical to make the diagnosis early. If you never know you have PCOS, every single stage of your life suffers from it. All right, I have now given you a long list of different ways in which one can make the diagnosis of PCOS. Well, guess what? Rarely do doctors take advantage of all of these things. Instead, in keeping with the short-sightedness on PCOS and all the focus on just your ovaries, the official diagnosis of PCOS rests on just 3 things. These are the official diagnostic criteria. To have a documented diagnosis of PCOS, you're required to have only 2 of 3 things: high testosterone, irregular infrequent periods, or multiple ovarian cysts on pelvic ultrasound. That's it. None of the other means of diagnosis counts in terms of the official diagnostic criteria for PCOS. So here's a comparison of all the possible indicators of PCOS versus the official diagnostic criteria for PCOS. See the big difference? There are 18 different possible indicators, of which only 3 are considered official diagnostic criteria. And if we designate just these 3 diagnostic criteria on our chart, you see that they all lie smack dab in the realm of only your reproductive life. They completely ignore anything after that. So now you see that I've highlighted these 3 diagnostic criteria in red. Well, because of this limited focus on just 3 diagnostic criteria, many women with PCOS never receive a diagnosis. And they fall prey to all the serious stuff that happens later in life. So now you see why it's important to know about PCOS and how to diagnose it. There's just no excuse for failing to diagnose it, but that's typically the case. The chart is your summary. You can find it by clicking on the link in the description box for this video, or you can go to menopausetailor.me. And the take-home message is to look for the manifestations of PCOS early in life so that you can avoid the disasters later in life. Please schedule a consultation with me at menopausetailor.me if you or a young woman in your life has any manifestations of PCOS. Don't wait. It is really easy to manage it, but everything has to be tailored to the individual. And the only means of tailoring is a consultation. Next week, I'll tell you all about management of PCOS. But until then, don't wait to schedule a consultation with me. And don't wait to subscribe to my channel and my newsletter. And don't wait to follow me on social media. And I can't wait to see you again in a week. Bye, my dears.